Hello and welcome to another episode of Cancer in Context. I'm Nicola Kamath, your host from AccessHope. At AccessHope, we support people getting access to the best cancer care in the world. And I'm proud to introduce Dr. David Jackman from Dana-Farber, one of our great partners. Dr. Jackman, could you introduce yourself?
Hi. Thanks so much, Nicola. I'm Dave Jackman. I'm a thoracic oncologist at the Dana-Farber Cancer Institute in Boston. I'm incredibly fortunate to serve a number of other roles at Dana-Farber. I am the medical director for our regional and national Dana-Farber collaborative and strategic alliances. I'm also the medical director for our clinical pathways program and new business initiatives, a portfolio that includes things like what we do with telemedicine and second opinions, including working with folks like AccessHope.
Well, it's great to have you to speak today, and you sure sound like you keep busy, Dr. Jackman. I thought we'd start for our audience. You have a really unique front lines lens into what does it life look like for a practicing oncologist today at Dana-Farber and across America?
It's a challenge. The field has changed so much over the last 5 years, over the last 20 years. When I think about the challenges that are facing physicians in every field, not just oncology, there's just so many things now that have come to the fore. Challenges of time, challenges of complexity, challenges of, existential threats to, is my practice going to survive? Or even, threats to the notion of science and evidence. Then we add on to that within oncology specifically, there's just been such an explosion of knowledge, of discovery in cancer biology, an explosion of drug development and therapeutics. And so putting all of that into practice is incredibly difficult. I'm incredibly lucky because all I do is thoracic oncology. So I only need to keep up with 4 or 5 diseases. I can't imagine being a community oncologist in this setting, and having to see 20 to 30 patients a day with 20 to 30 different diseases. How does one keep up with all of that and deliver best care? And I am always in such awe of how they do it and do it well, and always want to think, all the hats that I wear really have a central theme of how can Dana-Farber support patients and support care beyond our walls? And so what are some of the things we can do to make everyone's job easier?
That context, just hearing it makes me feel almost the weight of the world, and we hear how cancer incidence on top of it is increasing. Can you share a little bit about the work that Dana-Farber and Access Hope do together and how that plays into the oncology landscape as you see it?
Yeah, absolutely. I'll go back. When I was a young attending, I was incredibly lucky because I was in clinic with my mentor, Bruce Johnson, who was, really one of the international leaders in the field. And so if I saw a case, saw a patient and had questions, I could turn to Bruce and his decades of experience, and he'd be able to tell me, Dave, oh, yeah, think about this. And so needed to think about how do we provide that? How do we provide, that sounding board to people? And so one of the things that Access Hope and Dana-Farber as one of their foundational partners looks to do is how do we provide that sounding board? How do we provide that, that double check? Like, oh, I'll take a look at this case and yeah, you're doing everything right. Or, you know what? I noticed one thing. You might want to think about this too, because that sort of piece, when done in a way that is collaborative, when done in a way that's respectful, can really improve patient care, can make folks aware of, the subtle things that maybe we didn't think of, can make people aware of here's some clinical trial opportunities at my center or at centers closer to you that might be real opportunities for this patient. And so those are some of the ways that Access Hope is trying to bridge that divide.
With partners like Dana-Farber, who I might add, I am blown away by the level of innovation coming out of institutions like yours, but also the ability to synthesize all the different advancements in market in that you have the subspecialists, as you mentioned. It is much simpler and much more focused when you have subspecialists focusing on 4 types of a disease versus 400. That really resonates with me. Kind of gets me to the next topic of where do you think oncologists, both at your institution and across the country, are facing challenges, particularly when we talk about delivering evidence based care in a world where there's tons of information, but we want to make sure that the treatment actually matches the data that says it's going to be as effective as possible for that patient?
It's such a great question, and it goes, it hits to evidence not only about, I think people think a lot about what treatments should I choose, and that's just one part of it. It's the tip of the iceberg. With all of the advances, one needs to know enough about the biology to know what tests to order and how to interpret them to find what patient should get said treatment. How do we talk to the patient about that treatment, about what it can do, but also about what the potential side effects are? How do we develop the infrastructure to deliver that treatment? Because some of these are incredibly challenging. Sometimes patients need to be admitted to the hospital. Sometimes they need to be observed in clinic for 5 hours afterwards. So, how do we develop that infrastructure? And how do we safely administer and get patients through the treatment? And so, all of those steps are hard. It's not just one piece. And so, trying to put an evidence base upon every one of those layers is really important and is something that is being increasingly difficult. As we mentioned before, trying to keep up with such advances across such a broad array of cancers is challenging. And so what are the kinds of things that we can do? As I think about some of my jobs at Dana-Farber, when I was a medical student, one of the residents on the team I was on spoke about two kinds of learning. Talked about just in case learning and just in time learning. Right. So just in case learning was the lectures, the reading that you do, just in case you see this, disease sometime in a patient, you see this condition. Just in time learning is the learning that you don't fully have, but you know where to get it so that when something arises in the moment, you know how and where to access the information that you need. And so Access Hope kind of lives somewhere in between there. There's some of the things that they do, for the community in general. That is, from time to time, there are webinars, there are educational lectures. But more importantly, what do we put at a physician's fingertips, if not in real time, in near real time? You've seen this patient and we've taken a look at this case, and here's some things that we think would be helpful. Here's clinical trials that would be good here. And so how do we support both types of learning? Because I think that's incredibly key.
And I love that connection that you're talking about. It's not just about handing over, here's a referral, here's what should be done, but grounding it in evidence and being available for a one-to-one consultation, creating that community across oncology and that, like you mentioned earlier, and I want to actually revisit that topic about bringing folks together. You mentioned having the expert oncologist to learn from, ask for, and a whole neighborhood of resources around you. How do we create that in communities across America that may not have, you may be a sole oncologist practicing?
In this day and age, we're incredibly lucky that there's been a proliferation of digital tools. And so those are incredibly important places to learn more in the moment, to get knowledge. Things like, up to date, things like NCCN guidelines, things like our Dana-Farber Pathways program. How do we help physicians to make not just better, but easier and more efficient decisions? And so both more effective and more efficient. So those are incredibly important. But just as important are the meaningful human connections. How do we create things like tumor boards? How do we send patients back and forth, send information back and forth? And all of that is always going to be done better when there is a meaningful human connection within it, because it helps to create trust. It helps to create stickiness. People are more likely to use the tool. People are more likely to use the consulting service when they know the person at the other end, when they trust the person at the other end. And so how do we create those meaningful connections?
And I think it starts, as you're saying, with equipping their oncologist to have the information that they may not know, right? That, hey, this therapy is used in a different way, or here's a different take on what we thought we knew about certain diagnostics, and making sure that all of that is made easy, I expect, for the oncologist so that they can save their energy and their time to distill it down to the patient for the ultimate care decision.
Yep, that's right. Some of it is about knowledge sharing, and some of it is simply the act of connection. I'll share this. I come from simple folk. My grandfather had a hip replacement, and he used to pop out on him all the time. And every time it would pop out, he'd call 911 and ask for the cops and not for the EMTs. And we'd see him afterwards, like, Grandpa, why don't you ask for the ambulance? Because I know the cops. And that was a really important thing for him because that's who he knew, right? It was the kid that grew up on the block, and I know Billy, and so that was it was one of these things, right? And but that means a lot to people. And so for someone, for me, for anybody to be in practice and be able to say, you know what, I discussed your case with somebody at Dana-Farber, someone at Johns, wherever, at Johns Hopkins, at Northwestern, at City of Hope. I discussed your case with them, and they agreed with everything they were doing, and they added this too. And they said, you know what, if this stops working, here's some things that might be helpful. That's incredibly meaningful for patients to hear and for all of us to be able to share. I can't, tell you how much it means, if I'm seeing a patient and I need to send them off, and if it's somebody that I know, like that, human connections matter to us in everything that we do, whether it's trying to get a restaurant reservation or whether it's trying to figure out what's the next treatment for small cell. That being able to share what you learned and share, how that information was obtained is incredibly important.
I couldn't agree more. And I think that reference of your grandfather is actually each of us do that in a different part of our lives. It's also a reminder of community. And in a world that has evolved, how do we create your grandfather knew his local cops in that way? How do we create that community where, as you're saying, oncologists and folks that people trust are connected together and can facilitate a conversation that goes far beyond providing a case recommendation for an oncologist, but to the extent of helping reinforce and establish the trust with a patient. I trust my oncologist and I trust the specialist at these centers. I feel good about the care I'm being given, and I'm empowered to ask questions now because I feel so supported in this situation, and the connection really resonates.
The trust is on in every direction, right? How do we develop trust for patient? But how do we begin to trust and respect each other more? So that, oh, the docs at, you know, community practice in Maine and the docs in Boston share patients and get to know each other and how they practice, and then feel more comfortable sending patients back and forth. The Maine doc feels more comfortable sending me a patient in consultation, knowing that I'm going to send the patient back because I feel comfortable with the care they're delivering. It goes in every direction.
Again, I think that if we think about all the patients with cancer today, it's a very different world than we were living in 10, 15, 20 years ago, and that connection becomes all the more important. If you look to forward, Dr. Jackman, and if you could change one thing about what we do today that would help our future, what would it be?
Gosh, so many things that we'd like to change, right? As we think about tools, as we think about increasing conversations and bridging gaps to improve evidence based care, the thing that I would love is I think we need more and better patient-facing tools. I think we need to bring patients into conversations in a more meaningful way. We all mean it when we talk about putting the patient at the center of everything we do, and I think that's real. But I think that in practice, what happens sometimes is the patient's in the center, and there's a lot of physicians talking around them. And we need to figure out ways to talk to and through patients so that they feel connected to everything that's happened. And so one of those pieces is, when we do consults through Access Hope, for instance, making sure that patients are getting a copy. Patients are you're understanding, things that, wow, doctors mentioned that these were clinical trials that might be available to me. That's really useful information for them to have. How do we improve patient connectedness within these larger conversations?
I think it's a fascinating topic. And, was wondering, cancer gets really complicated. It's really interesting how you talk about doctors talking in a circle around patients. I could see how that might happen. How do you think about explaining the different therapies, explaining the different methodologies? Is it a matter of distilling complex information simply? Or do you think it's more of a matter of having a way to have these conversations because there's not much time with patients and you need another communication vehicle? Where do you think the problem lies within that?
You hit on a lot of it, right? Part of it is how do we make complex things easier? Part of it is how do we find the time to find the time and to take the time to do that. Patient facing tools are hard. When we create physician facing tools, we get to make certain assumptions. We know that the person that's on the other end of this tool went to medical school, did a residency, did an oncology fellowship, and so we get to assume certain things. Patients come from such a broad range of experiences and backgrounds. And so it has to be much more granular to be able to meet each one of them where they are. And so it takes time, it takes thoughtfulness. As we develop tools or just simply as we have conversations, how do we create the time and space for that? Do we need to bring them back? In this day and age, do we find ways for them to communicate with us in other ways, whether through email or through, virtual visits or other things where we can, take time outside of clinic to be able to have, some to answer their follow-up questions. But these are all incredibly challenging things and beyond the scope of any one conversation or beyond the scope necessarily of one tool. But we need to at least challenge ourselves to do a better job.
So, Dr. Jackman, clinical trials are a hot topic today. I'd love to understand your perspective of where do clinical trials fit in all of this information sharing?
Clinical trials are such an important part of oncology care and the development of the field in general, that every treatment that we have right now made it through the clinical trial process, a very carefully constructed evidence-based process. But the sad reality is that so few adult oncology patients are actually ever treated on a clinical trial. Fewer than 10% of adult oncology patients are ever treated on a clinical trial. In the pediatric center setting, that's 90%. So we need to do so much better.
And why are they underutilized? I'm sorry if it's a layperson's question here.
There's so many reasons. There is a lack of information about what trials may be available, lack of information to providers, lack of information to patients. For a long time, there haven't been good tools, web-based or otherwise, to allow providers and patients to understand what trials are available in this setting in my region. Those are things that we need to improve upon. But there's also, a much darker side to it. That some of it's information, but some of it's assumptions about, oh, this patient is too sick or wouldn't be able to participate in this trial. Some of it is that the trial process takes time and infrastructure, and community sites or sites in general may not have that time and infrastructure. It takes a long time to sit down with a patient and explain not just here's the standard therapy, but here's the clinical trial, but here's all the things you have to know about it. And so, being able to carve out that time is a challenging resource.
Yep. And I mean, you're speaking my language, and that is why we rolled out our clinical trial solution that within Access Hope, just last year because it helps with that whole enrollment and information sharing process. But beyond Access Hope, just thinking about clinical trials, what could this mean for patients?
It can lead to significant advances, right? The American Society of Clinical Oncology annual meeting happened 2 weeks ago. And at the plenary session, the main session, where five of the most groundbreaking trials were presented, my friend and colleague Brian Wolpin, the head of GI oncology here at Dana-Farber, presented their work on a new medication, daraxonrasib, in patients with metastatic pancreatic cancer. And when they showed the survival curves, the entire convention center stood up and cheered. It was that meaningful. It was a, there must have been a lot of pollen in the room that day because there was a lot, there were a lot of misty eyes, and so this is where we hope to get in every disease, right? That how do we develop drugs that are going to change the game, that are going to double survival for patients, and that are just going to be the next step in what's then going to be even further advances. But we don't get to that unless patients know about trials, unless patients are enrolled onto trials, and unless patients are encouraged to think about these as a potential and meaningful opportunity.
I'd love to talk about novel therapies now. Can you give me your perspective on what's out there and how you see it being applied in a way to support patients?
There has been such an explosion. We're looking at, CAR T cell and other cell therapies, bispecifics, antibodies that target not one, but two different things simultaneously. We're looking at therapies that have changed the game, but are also increasingly more difficult to deliver and to tolerate. And so it's not just a matter of knowing what treatment is right for this patient, it's how do we get them through this, especially if you have no experience with that. I think a great example is there's this drug amivantamab that was approved in lung cancer. And when it was approved in an IV formulation. And it was challenging because nearly 80% of patients who receive it develop an infusion reaction. And those reactions can be quite significant, so much so that they have to be observed in the infusion unit for 5 or 6 hours after the first few doses. And so that's something that a lot of centers didn't have the infrastructure and resources to do. Even within our own enterprise at Dana-Farber, we wanted everybody within our enterprise to send their patients specifically to our primary campus, our Longwood campus, or our Chestnut Hill campus, because we had a team in place that had expertise in this for those first few doses. And then once we got past that hump where the real concerns were, then we could send them back out to their oncologist at the site closer to their home. Right. So developing that knowledge, developing that expertise, developing how to deal with the infusion reactions, but also with the skin toxicities was really hard. And so these are the kinds of things where, that relationship between academic center and community center is so key because it's going to enable patients to get access to these treatments in a safe way. No, if that relationship exists, I need to get my first 2 or 3 doses at this place, and then I can get the rest closer to home. And so I can proceed with this in a way that is going to make most sense for me.
Dr. Jackman, thank you so much for joining us today. We've covered a lot of ground, and I'm really grateful to now count you within my connection and my community of folks that can really share their expertise.
Nicola, the pleasure was all mine. Thanks so much for having me.